Hello all, welcome to a short tutorial on the topic infective endocarditis. So what is infective endocarditis? It is a serious infection of endocardium of heart and mostly involves the heart valves. And major sites include heart valves, which is the most common, then mural endocardium, then congenital defects in the heart, then prosthetic valves. These all can also get involved. And the major lesions produced in infective endocarditis is first one is vegetation. Vegetation actually consists of a thrombotic debris plus microorganisms. Okay, so it is caused by microorganisms. So vegetations, which are mostly seen on the heart valves, consist of thrombotic debris and microorganisms. Thrombotic debris means it contains platelets and fibrins, and also then microorganisms, and also few inflammatory cells. And also, apart from vegetation, the destruction of the underlying cardiac tissue, that is destruction of the valves can occur, perforation and ulceration of the heart valves can occur in infective endocarditis. Then which are the microorganisms causing infective endocarditis? Most common organisms are bacteria, and also fungi, chlamydia and rickettsia can cause infective endocarditis. Then we can classify infective endocarditis into mainly acute infective endocarditis and subacute infective endocarditis. What is the difference? Okay, acute infective endocarditis is caused by highly virulent organisms. Those include Staphylococcus and Streptococcus pyogenes, mainly Staphylococcus aureus. It is highly virulent and that can even affect the normal valves of the heart. And it has a rapid course and it is highly destructive. It has very high mortality rate even if we treat with antibiotics. It is highly destructive, and while subacute infective endocarditis has low virulence, the organisms are low virulent organisms, mainly the virulent streptococci. This is the most common organism causing infective endocarditis. And subacute, in case of subacute, mainly damaged or deformed valves are affected, while acute infective endocarditis affect normal valves and also damaged valves. But subacute can affect only damaged or deformed valves. For example, the valves restricted in rheumatic heart disease or congenital heart diseases. And it has insidious onset, and it has slow course, and it is less destructive, and it has a good prognosis. Most recover with the antibiotics. Etiology. So the causative organisms are mostly the normal flora in our body, like the virulent streptococci are normal flora in oral cavity. Then staphylococci can be normal flora in few of skin in few people, and greater than 90% of infective endocarditis is caused by virulent streptococci and staphylococci. And Staphylococcus aureus causes acute infective endocarditis, and it is most common in IV drug addicts. And Streptococcus virulens, it is the normal flora of oral cavity, and it causes subacute infective endocarditis, and it is most common cause of infective endocarditis. Most common cause of infective endocarditis is Streptococcus virulens, while most common cause of acute infective endocarditis is Staph aureus. And coagulase negative staphylococci, for example, coagulase negative Staphylococcus epidermidis, that can cause prosthetic valve endocarditis. Then has a group of organisms like Haemophilus influenza, Actinobacillus, Cardiobacterium, Eikenella, Kingella. These can also cause infective endocarditis, and also some other gram-negative bacilli and fungi can also cause infective endocarditis. So what are the predisposing factors? Predisposing factors include conditions that causes bacteremia and underlying heart disease and impaired host defense mechanism. What are the conditions in which bacteremia occurs? Like obvious infections in our body, then dental or surgical procedures, urinary catheterization, obstetric procedures, IV drug abuse, then break in epithelium of GIT, oral cavity, skin, like if the virulent streptococci, for example, virulent streptococci can enter into our blood when if somehow oral ulcers, and that can lead to infective endocarditis. Okay, and next factor is underlying heart diseases, like congenital heart diseases, mitral valve prolapse, chronic rheumatic heart disease, then prosthetic valves, vascular catheters, then impaired host defense mechanism that occurs in diabetes mellitus, malignancy like leukemia, lymphoma, then cytotoxic therapy and neutropenia. These all conditions can predispose to infective endocarditis. And how can we prevent this? It can be done by antibiotic prophylaxis in people with the increased risk. Okay. Now the pathogenesis. Actually, first step is endocardial injury. An endocardial injury can actually cause non-bacterial thrombotic endocarditis. Actually, injury can expose the subendothelial collagen, and that can activate the platelets and activate the clotting pathway. That can lead to thrombi formation, and that thrombi is called non-bacterial thrombotic thrombus, or and the condition is called non-bacterial thrombotic endocarditis. It is a sterile vegetation. And further, when bacteremia occurs, these microorganisms adhere to the sterile non-bacterial thrombi and using certain proteins called adhesins, and these microorganisms then proliferate within the vegetation, non-bacterial thrombotic vegetation. Microorganisms proliferate within this vegetation, and it is further covered by layer of platelet and fibrins, and within that vegetation these microorganism grows, and that can further lead to infective emboli formation. Actually, this vegetation can detach from the heart valves and then become an infective emboli that can further travel through the blood vessels and can lodge in other organs, blood capillaries of other organs, leading to infections and spread of infection to the visceral organs and also brain. Coming to the morphology, most common site is aortic and mitral valves, and in IV drug abuses, most common cause is tricuspid valve, and the appearance is like it is friable, irregular, and bulky vegetation, and these vegetations are the hallmark of infective endocarditis. And it is mostly coming to the location, the vegetations in AV valves are towards the atrial side, and in the vegetations in the semilunar valves are mainly towards the ventricular side. And sometimes perforations or ulcerations of the valves can be seen, and perforations can lead to regurgitation, valvular regurgitation. Then in microscopy, the vegetations consist of fibrin, platelets, cell debris, and inflammatory cells, and also colonies, many abundant colonies of microorganisms. Then granulation tissue can form at the base of the vegetation that can further heal by fibrosis, and then may calcify in some cases. And these can sometimes lead to stenotic lesions of valve. So this is the gross appearance of vegetations on the valves. These are actually bulky, friable, irregular masses. And in semilunar valves, these vegetations are towards the ventricle, and in AV valve it is towards the atrium vegetations. Okay, this is the valve, and vegetations are towards the atrium in AV valves. And this is the microscopy. This is the heart valve, and you can see a layer of fibrin and platelets, and deep to that you can see many bacterial colonies, many bacterial colonies, and deep to that we can see inflammatory cells. So what are the components of a vegetation? So it includes outer layer of platelets and fibrin, then deep to that many abundant microorganisms, and deep to that many inflammatory cells. And now the clinical features. The general features are fever, chills, weakness, new onset heart murmur, or a change in an existing murmur. Okay, new onset heart murmur or a change in an existing murmur. And the peripheral stigmata of the infective endocarditis include those are due to microemboli or immune complex deposition, and those include Osler's node, which are tender subcutaneous nodules on fingers, and that is due to immune complex deposition, and Janeway lesions. Okay, so these are oscillate nodes. These are subcutaneous nodules. Subcutaneous painful. Okay, oscillate nodes are painful seen on the fingers due to immune complex deposition, and Janeway lesions are non-tender. They are not painful, and they are erythematous hemorrhagic lesions on palms or soles. These are the Janeway lesions. These are hemorrhagic lesions due to emboli, and these are not painful. Next lesion is rod spot, which are these are the rod spot which are seen on the retina. These consist of a reddish hemorrhagic lesion, inside which you can see a translucent center. And next lesion is splinter hemorrhage, which are linear and dark red streaks under the nail beds. Okay, so these are the splinter hemorrhages. So which are the peripheral stigmata of infective endocarditis? Those are oscillate node, which are painful subcutaneous nodules, and Janeway lesions are painless hemorrhagic lesions, and splinter hemorrhages on nail beds, and also rod spot, which are seen on retina. Now the complications are cardiac complications and extracardiac complication. Cardiac complications include valvular insufficiency or regurgitation lesion. Regurgitation occurs in due to perforation of the valves, and heart failure can occur. Actually, most of the patients in acute infective endocarditis die because of the heart failure or sepsis. And other complication is myocardial ring abscess, then suppurative pericarditis. Extracardiac complications can be due to emboli or immune complex deposition. Immune complex deposition can cause glomerulonephritis, and due to emboli the complications are infarcts in brain, spleen, kidney, then pulmonary emboli or infarcts, and also mycotic aneurysms can occur. Then the diagnostic criteria, it is called Duke's criteria, and Duke's criteria says that for in order to diagnose infective endocarditis, there should be at least 2 of these major criteria, or 1 major criteria along with 3 minor criteria, or 5 minor criteria positive. So these are the major and minor criteria. Major criteria include positive blood culture, then echocardiographic identification of valve related or implant related mass or abscess. Okay, so first is blood culture should be positive, that is first major criteria. Then second is cardiac echo should show any valve or valve related mass, that is vegetations or any abscess. Then new valvular regurgitation. These are the major criteria. Out of this, if 2 are positive, that means we can say that it is infective endocarditis. If only 1 major criteria is there, then 3 of the minor should be positive. And minor criteria include fever, predisposing heart lesion, or IV drug abuse. These are the risk factors. And vascular lesions like arterial petechiae, subungual or splinter hemorrhages, then emboli, septic infarcts, mycotic aneurysm, intracranial hemorrhage, Janeway lesions, then immunological phenomena like glomerulonephritis, oscillate node, rod spot. Then microbiological evidence including a single culture positive for an unusual organism. Okay, these are the minor criteria. These mainly includes the clinical features of infective endocarditis. And also one more is that microbiological evidence including a single culture positive for an unusual organism, an organism that usually does not causes infective endocarditis. Okay, so that's all about infective endocarditis. I hope you all understood about this topic. If you like this topic, please like, share and subscribe. Okay, thank you.